right. Craig, I think we'll start. You're good with that? Let people trickle in here. It's my pleasure to be here today. My name is Glenn Hansen. I'm the Chief Medical Officer for CGene US. And it's my pleasure to introduce colleague and friend, Dr. Blake Buchan. Blake is well known to many of us in the room as a key voice in diagnostics. He lives in the part of the country that this talk will be most relevant with. We're excited to have Blake here. Blake is a professor of pathology at the Medical College of Wisconsin in Milwaukee. He sits on a number of ASM committees and is on editorial boards for both JCM as well as clinical pathology, so he's well known to us as well. And he's here to talk about what we believe is a emerging diagnostic threat. The implications of tick-borne disease, for those of you, I see a few friendly faces from the Northeast in here, a few from the Midwest, even the Southeast now. Tick-borne disease is on the rise. And so we're privileged to have Blake give his perspective on tick update, tick populations on the rise, epidemiology, diagnosis, and clinical significance. So without further ado, Blake, welcome.
Thanks, Glenn. And thanks everyone for coming. It's good to see a good crowd and familiar faces as well. Like Glenn mentioned, it's a topic I've given a few talks on before. I really kind of enjoy it. It's kind of an emerging area, and I think the complexity is increasing as we're recognizing more pathogens. So without further ado, I'll kind of get into the slides here. Just got my standard disclosure slide, so blink and you miss it. So we'll start with sort of the burden in epidemiology, kind of setting the stage. Lyme disease historically is thought of as sort of the apex predator for tick-borne illness, and it's used as the canary in the coal mine. And so you can see with reported cases of Lyme disease over the past 2 decades, we've seen a very steady rise, about twofold. But if you look at pathogens other than Borrelia burgdorferi, you see a similar increase in prevalence for things like Ehrlichia, Anaplasma, Babesia, and Rickettsia. But in the cases of especially Ehrlichia and Anaplasma, we've actually seen a 10 to 19-fold increase in reported cases over that same time period. Some of that is due to the availability of better diagnostics, some to recognition, but at any rate, I think these can no longer be really brushed off or ignored. So what I think I'm saying is, this is really the tip of the iceberg is what we're recognizing. So what is the real incidence of tick-borne infections? And again, Lyme is used kind of as the model here, and there's a couple of studies, if you're into tick-borne illness, you're probably familiar with. But there was one conducted in 2008 that was a survey of large reference laboratories and the Lyme serology testing they were doing. And this encompassed over 3.4 million tests for Lyme in 2008 among these reference labs. And the positivity ranged from 10 to 18%. So based on that, that equates to 1/4 to 500,000 possible Lyme disease infections. And that's 5 to 10 times the reported rate that I was just showing you of maybe 50,000 a year. 5 years later, the CDC did a similar study looking at the prevalence of Lyme disease, and they reviewed laboratory reports from Lyme endemic labs, and they came up with a very similar estimate of about 300,000 infections annually, which again was somewhere between 8 and 10 times the reported incidence in that year. And again, this is just Lyme disease. And so why are we seeing this increase in Lyme and other tick-borne pathogens? I think it's due to several factors, including increased recognition. Tick-borne illness, TBI, is higher on the clinical differential. Physicians are thinking about it more, especially in infectious disease, immune-compromised patients, and even in initial evaluations in the ED. So I think more testing is being done. We've got ecological factors playing in. The vectors that I'll talk about in a moment are increasing in range. The ticks are increasing in range. We're recognizing new tick-borne pathogens. There have been a number of new Borrelia species as well as viral species like tick-borne encephalitis virus that have just been recognized in the past decade or so that are contributing to these illnesses. And finally, we're getting better diagnostics. Our approaches through molecular and other techniques are more sensitive and specific than traditional methods that are based on serology or blood smear. And we're getting broader availability of these. Historically, tick-borne pathogen testing was really centralized to a lot of national reference laboratories. As we're able to decentralize this to routine academic centers or even community laboratories potentially, I think this is just going to increase the availability, increase the ability to test for these pathogens, and then increase diagnosis and recognition of these pathogens. So this is just a slide that's it's a heat map that just further kind of demonstrates the expanding range of, again, really just Lyme disease, because that's the one we have the best handle on. And so this is from AJCP, published in 2019. And you can see the positivity rates in these heat maps. And so in panel A, we have 2010, and you see the highest positivity in New England and the upper Great Lakes area, classically thought to be endemic for Lyme. And then by 2016, that heat map expands. We get darker orange in those two endemic areas, but we see more orange spreading really throughout the entire United States, including the South. One of the reasons contributing to this probably is the weather. I think, the cause is maybe debatable, but the fact that we're getting warmer winters is not debatable. And so you can see it's actually a cold map, I suppose, of the longest sustained cold temperatures. And in 1970, you can see all of the upper Midwest had long-term sustained temperatures below 10 degrees Fahrenheit. And by 2016, that really shrunk significantly. And so the impact of this is that we're expanding our tick season, okay? Happens later, you can get infections later and exposures later into the fall. You've also got the environmental reservoirs, natural reservoirs, like small mammals that carry these tick-borne pathogens, and they're surviving these more mild winters. And so you have a larger reservoir base as well. So these pathogens are maintained in nature. And this is just one last set of maps that I like to show that shows the expansion of one specific tick, Ixodes scapularis, which carries and transmits really a large number of these tick-borne pathogens. And you can see, of course, because of weather and et cetera, the expanding range between 96 and 2006. And the cases of Lyme disease, as you would expect, also expanding. One of the interesting things on this map, though, is that you see in Florida, while the Ixodes tick has expanded into Florida, we don't have more Lyme disease in Florida. And so you might say, why is this? And it's because of the interaction we have for these tick-borne illnesses, right? It takes three to tango. You need the vector, the tick, to transmit these organisms, but they need to get it from somewhere. And so they get it from the natural reservoir, which are usually small mammals. And as it turns out, those mice aren't native to Florida. And so while you have the tick in the human, you don't have the reservoir. So you're not seeing a lot of Lyme disease in Florida typically. Other things that contribute to expanding tick-borne illness include urban development. We're eliminating predators for the environmental reservoir, so you have more mouse populations that are not being cleared out by coyotes and those sorts of things. You have people, especially during COVID, getting outside more, being more in contact with nature, and just increasing their exposure. So these are all things that kind of contribute to some of the rise we've seen in tick-borne illness. So the next few slides I'll go through who are the actors here. Who are we talking about when we think about tick-borne illness? Of course, we can't have a talk without talking about Borrelia burgdorferi. This causes your classic Lyme disease associated with your erythema migrans rash in 80 to 90% of patients, fever, fatigue, arthralgia, all the symptoms that you're familiar with. The danger in these, and the reason we need to make an early diagnosis and treat, is that if they go untreated, you run a risk for more significant secondary sequelae, including chronic neurologic, myocarditis, neuroborreliosis, and those sort of more severe diseases that, again, if left untreated, can manifest after the initial symptoms of rash and fatigue. The tick that transmits these, again, is the black-legged tick, Ixodes scapularis, and the environmental reservoir is the white-footed mouse. And you can see the range here. And so the tick is prevalent pretty much throughout the eastern United States, whereas the mouse is eastern United States minus Florida. So this is great for Lyme disease. This is where we get the idea of regions of endemicity. But in 2016, Borrelia mayonii was characterized. And Borrelia mayonii shares a lot of genetic similarity to Borrelia burgdorferi. It's associated with sort of a Lyme disease type symptom or disease. But when you look sort of clinically at the rash, it's different. It's not that classic bullseye rash. It's more of a diffuse macular rash. It can be associated with more neurologic symptoms. And so the clinical presentation is a little bit different. And another thing that's different about this organism, from a diagnostic standpoint, is that it reaches a really high spirochetemia in the blood during acute symptoms. And so that makes your diagnostic approaches potentially a little different. Again, it's transmitted by that same tick, and we don't know the reservoir for mayonii, and currently cases are really limited, but that's probably due to the fact that we're not looking for it. On the other half of the country, in the West, we don't have Lyme disease per se. The Borrelias that we have cause relapsing fever, and these are transmitted by the soft-bodied ticks. And so this disease is different than Lyme disease. You get a rash, but it's not, erythema migrans. And you typically have series of relapsing fevers that get less severe as you go through the third or fourth fever cycle. Oftentimes self-resolving and oftentimes undiagnosed because they don't necessarily cause severe enough symptoms and protracted enough symptoms for people to go seek medical care. On the third day of fever, they start to convalesce and say, I feel better, and then they kind of relapse, right, 4 or 5 days later. So we're not seeking care, and we don't have a lot of good diagnostics for these organisms. Again, these do have a very high spirochetemia during febrile episodes, so you can actually see these in peripheral blood smears. And so this is where we get the idea of Western ticks and Eastern ticks and relapsing fever versus Lyme disease. But in the year 2000, Borrelia miyamotoi was recognized, very similar genetically to the relapsing fever Borrelias, cause relapsing fever. They can cause invasive neurologic disease, so a little bit more severe than the other relapsing fever Borrelias. But the real change here is that this is now transmitted by that same black-legged tick. So now we get relapsing fever not just in the West, but also in the East. And so you can already see how, judging what diagnostic test you're going to order based on historic epidemiology gets a little bit cloudy. So how do we diagnose these different Borrelia infections? Well, for Borrelia burgdorferi, we've historically relied on a serologic approach. It's a two-step diagnostic approach that I think everyone should be familiar with, but it's certainly not ideal. When somebody comes with acute symptoms, they're in that serologic window. And so when you have a rash and you have exposure, serologic tests may be as little as 25 to 50% sensitive. So it's not good for diagnosing those acute infections. And again, it's important to diagnose those and treat so you don't get the later manifestations. When you get to a later manifestation, the serologic tests are really good. They're better than 95% in most cases. Specificity can also be an issue with serologic tests. There's cross-reactivity with other spirochetes. And really importantly with serology, one of the big downfalls to serology is it can't necessarily differentiate current versus past infection. And for people who live in Lyme endemic areas, you may have an unrecognized infection 5 years ago. Now you get febrile, you present, you get a Lyme serology, and you turn positive. So you're misdiagnosed as Lyme disease, even though you may have anaplasma or babesia or a different tick-borne illness. And that has both prognostic and treatment implications. In 2018, CDC endorsed a new two-tier algorithm, actually uses recombinant proteins, so it's more specific to Borrelia burgdorferi, which you would think would be beneficial. It actually detects earlier infections, so it's a little bit better for those acute phase infections, although certainly not perfect. But the downside to this is you lose that cross-reactivity with other Borrelias that you may not have recognized in the past. And so even though it was a misdiagnosis in the past, you could say, okay, it's a Borrelia, I'm going to call it Lyme disease, even though it's maybe Mayonii or Miyamotoi. And fortunately, these seem to respond to doxycycline. So even though it's a misdiagnosis, you still said you've got a spirochetal infection and we're going to treat. With this new, more specific serology, these patients would oftentimes be negative. And so you're just missing these sort of fortuitous catches. So because of these regions, serology is not really recommended for patients with recent exposure and erythema migrans. It's a clinical diagnosis based on rash, based on symptoms, based on exposure. And historically, you just treat, which can lead, again, to overtreatment in some cases. Can we use PCR for Borrelia burgdorferi? And the answer for this is unfortunately not really. Borrelia burgdorferi is a little unique in that even in acute infections, it only reaches a spirochetemia of somewhere between maybe 500 and 1,000 spirochetes per mil of blood, which is really at the limit of detection of PCR a lot of times. And so in the early acute phase, while serology is negative, PCR can be positive, but maybe only 30 to 50% sensitive. And in convalescent cases, in those later phases, PCR is essentially useless. But again, at that point, the serology tests are very good. The benefit of PCR is that it's highly specific. So you don't have to worry about a PCR being positive and indicative of a past infection. If you do catch it, certainly that's indicative of a current active infection. And so while PCR is not recommended for primary diagnosis of Lyme disease, I think it's a really valuable target to have in a panel-based approach. Because if you're evaluating acute infections, you will pick up 30 to 50%. And I'll show some of that data in a paper that I present in a few slides. For the other Borrelias, it's a different story. In these cases, the spirocatemias are sufficiently high that you can see them in smear, but of course PCR is going to be much more sensitive. But now that we recognize all these different species, we have to be able to encompass them. So we need that multiplexing. We've got a lot of Borrelias here that we need to capture. You can see the spirochetes in the top panel in a blood smear. And in that bottom smear, this is a picture of a CSF specimen that recently circulated on ClinMicroNets out of Dr. Kubiak's lab in Minnesota. This is an invasive Borrelia miyamotoi infection, a neuroinvasive infection. And so you can actually see the spirochetes there, which is sort of pretty cool given it's a CSF specimen. So, these PCR tests can be applied not only for these species to blood specimens, but also potentially other specimens when you have neuroborreliosis. And that's what this says. So, we've talked about these. We kind of have a sense of what might be out there. There's not a lot of studies that have largely just used a multiplexed PCR approach to confirm what we think is true. This study looked at over 7,000 specimens from patients being evaluated for tick-borne illness, Lyme disease specifically. And as you might expect, a large percentage were negative. We only had less than 1% of these were positive. But the pathogens they picked up were kind of interesting. Of the Lyme disease-causing Borrelias, a quarter of them were Borrelia mayonii rather. And so even though it's sort of a novel organism, we see it's accounting for a large percent of the Lyme disease Borrelias that are detected when you look for them. And on the relapsing fever side, 80% were Borrelia miyamotoi, which again is really throughout the East, so probably not doing a lot of testing for these otherwise. So they're certainly out there, and this is a paper from 2023 in EID that shows again this rapid increase in Borrelia miyamotoi infections that are documented, and still the N is only 90, but again we're not looking for these. So this is a really small survey, so it's actually quite amazing that we're actually finding this many, given the really limited testing that's going on right now. So really the take home from this is that novel Borrelia species do account for a significant proportion of infections, and the use of a broad molecular multiplexed approach would be very effective in helping us identify these and discriminate these. So beyond Borrelia, we don't want to ignore the other tick-borne pathogens that we talked about. There's ehrlichiosis. There's a couple of species. There's several species, but we really think about Chafiescens and Ewingii primarily, cause similar symptoms to the Borrelia infections, but can actually be more severe, again, if untreated, especially in compromised patients. These are not transmitted by the black-legged tick, so we find them more in the southern United States classically. However, again, there's a new species, Ehrlichia mirus, that we actually do see in the north, and it's transmitted by the Ixodes tick. So again, you see a breakdown of what we've considered, historically, epidemiologically, Ehrlichia's here, Anaplasma's there. We're seeing a lot of overlap now because of these new pathogens that are transmitted by different vectors. And likewise, Anaplasma, extremely common in Wisconsin. We see this, quite a bit. Similar symptomology, although less severe symptoms than Ehrlichia. So these are just, again, painting the picture. And the last pathogen, as far as diagnosis, how do we diagnose Ehrlichia and Anaplasma? Historically, we can do a blood smear looking for these morulae, these parasitophagus vacuoles, right, in granulocytes or monocytes. But these are typically poorly sensitive and specific. You can have sort of transient presence of these organisms, and early in disease, we don't see a lot of morulae. So especially early in disease, the sensitivity of blood smear can be fairly poor. Serology has that same issue with diagnosing acute infections. You haven't generated an immune response yet. And so you miss these early infections when patients are presenting. So it's more of a retrospective diagnosis, which doesn't help when you're trying to target therapy. Okay, so can we apply PCR to Anaplasma ehrlichia? Certainly can. We know the limit of detection for PCR for these organisms is very low. PCR has been shown to be 100% sensitive compared to smear, and actually identifies up to 20% more infections in both acute and late phase infections. And so because of this, PCR can be recommended as a primary test for Anaplasma and Ehrlichia. So here's the last pathogen I'll talk about. It's Babesia. Again, we've got a couple species. We think primarily of Babesia microti. This causes infections largely in the east and upper northwest and upper northeast and Midwest.
and oftentimes can be self-resolving if you're immune competent, but can cause severe disease in asplenics and immune-compromised patients. And the other species is Babesia duncanii, which we see more on the West Coast and in Canada. These do cause more severe disease, and there's some literature suggesting that they're somewhat treatment refractory as well. With any Babesias, these aren't responding to doxycycline like our Anaplasma, Ehrlichia, Borrelia. So again, really important to specifically call these out when you're thinking about tick-borne illnesses because it has treatment implications. Again, these are transmitted largely by the black-legged tick. You can see the organisms, they're intraerythrocytic, they make the ring forms, they look like plasmodium, real cool blood smears. But again, early in infection, this parasitemia can be low. So when patients present, you may have a low sensitivity for blood smear. PCR, again, has no problem picking up as little as 0.1% parasitemia. So, much like we saw for Anaplasma and Ehrlichia, smears are only 85% sensitive compared to PCR, and PCR is much better to diagnose those early acute infections. So PCR can be recommended for a primary test. Okay, so that was the epidemiology and the actors. So now we can talk about these molecular methods. What's out there? What are we talking about when we talk about molecular methods? And what are some of the limitations? So real-time PCR, this is AMP, right? Everyone's familiar with real-time PCR. You extract your sample, you have your template, and you put in your polymerase primers, et cetera. But for multiplexing, still, the majority of platforms out there use fluorescent-based technology, 4 to 6 channels, and so that limits your multiplexing capabilities. I've just gone through a laundry list of pathogens, both classic and emerging, that we need to be thinking about. And so you run into real bottlenecks with the ability to test for all these using a classic, 4 or 6 color thermocycler. So Cgene's technology, and I'll give a general overview of this. You can speak with the Cgene folks for nitty-gritty details. But it differs from standard probe-based PCR or TaqMan probe PCR in that in the primers, they also integrate a tail, right, that doesn't necessarily bind. And so that gets integrated into the amplicon. And once you have amplicon, now instead of targeting a fluorescent probe to a specific amplicon, you can target a probe, maybe 2 probes or 3 probes that have the same fluorophore to that engineered tail. And through different extension temperatures or melt analysis, you can then differentiate different targets, different amplicons, within that same color channel. And so that allows you to expand your 4 or 6 color thermocycler to anywhere from 8 to 24 colors, depending on how many of these different tailed primers and targets are in each channel. So this allows your workflow to be the same as you've always used for real-time PCR. You have your specimen, there's various automation to extract and set up your PCR plates. You can run these on existing thermocyclers like Bio-Rad's CFX thermocyclers. And then while the chemistry is really unique and complex, the readout is not. All of these data go into the Cgene viewer software, the melt curves get deconvoluted, and you're just left with a detected or not detected, along with a CT value for each of the targets that's contained in the assay. So it doesn't change your workflow. You can run this with a lot of times existing infrastructure, which is really valuable for labs that are trying to maximize the instrumentation that they have. And this can all be done certainly in one shift. So daily turnaround. So of course Cgene's not the only the only game in town when it comes to tick-borne testing, but I think it has some certain advantages. I'm not going to go through this whole table, but these are some of the other players in the field. Diasorin has analyte-specific reagents. They have them for Borrelia species, but they're non-differentiated, so relapsing fever versus Lyme disease. They have a primer set for Anaplasma and a primer set for Ehrlichias, undifferentiated. These would all have to be run in 3 parallel reactions, or since they're ASRs, you could put them together in a single reaction. It would be up to you to validate that and optimize to make sure you're not losing sensitivity and that the floors all play well together. ELITech has 4 different RUO tests that cover Borrelia Lyme disease causing species, relapsing fever causing species, but again, these are undifferentiated, as well as Ehrlichias and the Babesias, again, undifferentiated.
Well, in some cases, they're differentiated. Microtes broke out from Duncanii and divergens. Chromacode uses another sort of high-definition PCR approach. It's a probe-limiting approach, and that allows them to look for 9 organisms in a single well. And so they do a pretty good job covering a lot of these, but even the Lyme disease-causing Borrelias, like Burgdorferi and Mayonii, are reported as a slash line. They're not differentiated. And I think it's really going to be powerful to call these out accurately to see if there's differences in, prognostically in clinical presentation, disease presentation, and evolution. So I think the more you can differentiate these out and get an accurate diagnosis, the more we're going to learn about these, and the more we'll be able to better manage these, translate this into guidelines and management guidelines. So Seegene, again, using their technology, can also put 9 in their current tick-borne pathogen assay, 9 targets. And where they excel is, again, they're really breaking these out. They do break out Burgdorferi and Mayonii and Miyamotoi, so the important Borrelias we talked about. They break out Microtii and Duncanii. Again, Duncanii maybe not responding to therapy as well. And so they give a much more granular result than the other tests that are currently out there. So we're bringing in molecular. If we're throwing away cheap blood smears and cheap serology tests, we want to make sure we can get paid. Historically, there has been a CPT code for Borrelia burgdorferi PCR, which I told you is not that useful. And then other than that, for these other tick-borne pathogens where there actually is utility of PCR, you'd have to use this 87798 basic code. And you run into problems with that sometimes with payers because you're not necessarily tying a pathogen to that. You just say, oh, I'm going to charge 87798 times 5 or times 6. And as we all know, there's downward pressure on reimbursement. Payers are looking at these codes more objectively, and this may result in delayed payment or non-payment because of code stacking or just a misunderstanding. So in 2023, actually, very fortuitously timing for the talk, there's some new CPT codes that were introduced. And so now there's specific CPT codes for PCR, for Anaplasma, B. microti, Borrelia miyamotoi. So to me, this signifies a real recognition that not only is this out there and worth testing, but there's enough test volume going on at some reference labs, and that PCR is a reliable method that deserved its own code. And then of course Ehrlichia as well. So I think this is going to help when we move to these panels to actually ensure better reimbursement. All right, so that's all that stuff. I'm going to finish up just taking you through an overview of 2 studies I've done where I've used multiplex tick-borne pathogen panels in an adult population and then in a pediatric population to kind of see what's out there and maybe what we're missing and where we could improve diagnostics if we transition to this approach. So this first one was published in the Journal of Clinical Microbiology in 2019. And in this study, it was based on specimens obtained in Wisconsin. We partnered with Gunderson Medical Foundation, which is in a rural part of northwest Wisconsin. And then I'm at the medical college in a more urban portion of southeast Wisconsin. And we enrolled 505 prospective clinical specimens from patients that came in to be evaluated for Lyme disease or other tick-borne illness. We had 425 patients being evaluated, and then of course we had 80 patients that were not being evaluated. These were just like CBCs and things like that we wanted to enroll to make sure that the test was not throwing false positives in patients who didn't have risk factors for Lyme disease. You can read the paper on your own. I'll just present one table, kind of the take-home table. Of course, we compared to a gold standard that was composite. We had singleplex PCRs for many of these targets. It's serologic tests, blood smears, clinical history, exposure, etc. But the take-home after this is that we found 6.4% of these specimens in the symptomatic group being positive by the tick-borne pathogen panel or the reference test. And in our asymptomatic cohort, none were positive. So we're not throwing false positives, which is always a good thing. When we look at some of the independent targets, the data actually got really interesting. For Anaplasma, we had great performance, 100% sensitivity, but among these 11 specimens that were positive for Anaplasma, 2 were also seropositive for Lyme. And so in these cases, this is probably representative of an active Anaplasma infection and a past Lyme infection that was self-resolved or treated in the past. And so in these cases, when you order just Lyme serology, you see you're missing potentially the cause of the infection. So you're catching those things with a PCR-based test. When you look at your Lyme disease causing Borrelias, as you might expect, we had variable performance because of Borrelia burgdorferi having that low spirochetemia, low sensitivity in acute infections. But of the 9 that we detected with PCR, 0 were seropositive. So you would have missed all of them with the available testing. So this is why, even though our sensitivity is not great, you can see you pick up a lot of additional, or at least some additional infections, because these are acute infections where you can pick them up by PCR and will not pick them up with your serologic methods. And one of the 9 was actually Borrelia mayonnae. So even though it's recently described, it's out there. This is just a prospective cohort. So again, I think evidence that we need to be considering these organisms. Same thing with Borrelia miyamotoi. We detected 2. So 2 of 23 positive detections were miyamotoi. That's like 9% of everything we detected is this novel Borrelia species that, especially with our updated, more specific serologic tests, our modified 2-tier tests, we're going to miss these if we don't use a different approach. So again, really, really important. And then we actually picked up a rickettsia, which we don't think of as much in Wisconsin, and certainly we wouldn't think of PCR as being a first-line test. But as part of a multiplex panel, you're going to catch unexpected pathogens once in a while. And I'm not going to tell you the sensitivity is 100%, but you'll catch these. And this was actually confirmed by CDC. We sent the specimen there to confirm, and they confirmed the identification. Okay, so that was in the adult population in a study conducted exclusively in Wisconsin. The other publication we did was looking at the pediatric population. And this was done, our aim here was to determine not only the prevalence of tick-borne infections, but also co-infections in children that are presenting to the emergency department with risk factors for Lyme disease or other tick-borne illness. This study, we were fortunate enough to partner with PD LymeNet, which is a group of 8 children's hospitals in Lyme endemic states. They had banked over 3,500 blood specimens from kids being evaluated for Lyme disease, as well as matched controls. And this study was actually funded by the Emergency Medicine Foundation. So again, there's interest from emergency medicine in looking at tick-borne illness as well. So I think it's getting on the radar of more provider groups. In this study, it was a nested case control study. We had 612 total specimens, 307 Lyme cases, and 305 what we considered clinical mimics. And so we defined Lyme cases as any patient positive for Lyme disease by 2-tier serology, along with compatible symptoms. Only 18% had erythema migrans lesions that were clearly defined. And then our clinical mimics had similar symptoms. They were matched by age, gender, etc., but did not test positive or had no indication that they had a Lyme infection. And when you looked at recognized tick bites in these groups, we also controlled for that, so the exposure was also there. So we blinded these, of course, and tested them all using a multiplex tick-borne pathogen panel. And what we found is that it worked. We had some invalids, of course. These are whole blood samples, by the way, because we have intraerythrocytic pathogens. We can't use serum. And so you're going to sometimes get invalids because of the heme and that sort of thing. But overall, it worked pretty well. More interestingly, what we found was 4% of specimens from the Lyme disease cohort were positive for Borrelia species, 10 for Lyme-causing Borrelias, 2 for relapsing fever-causing Borrelias. That was compared to only 1 in the clinical mimic group. And then when you look at the other pathogens, this is where things really kind of, in my opinion, got interesting. We saw 15 positives, or 5.1% of specimens obtained in the Lyme disease cohort were positive for non-Borrelia pathogens. In this study, because many of the specimens were from the Northeast, we saw a lot of Babesia, but we also saw some Anaplasma, some Ehrlichia, and so these were all missed because none of these patients were being evaluated for these other organisms. Now, are these important clinically? When we look at these 15 specimens that had non-Borrelia pathogens, you can see the pathogen, where they were obtained, the presenting symptoms. But the important part is that a third of them, 5 of the 15, were admitted because of their symptoms. And so these co-infections may either be synergistic or may be more severe, at least acutely, than just Borrelia burgdorferi or Lyme disease infection. So again, important to identify these co-infections, which are present in, as I showed, up to almost 6% of patients being evaluated for Lyme disease. So those are the conclusions of our study. We found 5.7% of pediatric patients that were diagnosed with Lyme had undiagnosed co-infections. To me, that's a pretty big number. And you can see, again, the breakdown, largely Babesia and Anaplasma. This would obviously change depending on where you are in your local epidemiology, but that was kind of the power of this study, having 8 pediatric centers throughout various regions. I think there's, the data supports a potential risk for protracted symptoms or severe disease if these co-infections are unrecognized. None of these patients, and remember Babesia was our most common co-infection that we identified, none of these patients had received Babesia active antibiotics. And again, a third of them were then admitted for their symptoms. So I think it's, again, important to recognize these from a management standpoint. So my overall conclusions from this talk are that clearly cases of tick-borne illness are steadily increasing. We're recognizing these infections. We have new pathogens. We can't rely on clinical or epidemiologic assessment to guide targeted testing. We need a broad approach, again, because of the new pathogens, overlapping ranges, expanding ranges, all the things that we kind of talked about. Our current diagnostic methods based on blood smear and serology are really inadequate for most of these pathogens due to poor sensitivity, inability to diagnose acute infections, misdiagnosis of past infections as acute infections, and that sort of thing. And my second conclusion slide is that molecular diagnostics then can be a useful adjunct. I don't think it should replace Lyme serology. In some cases, you may want to do a blood smear first. It's rapid, it's inexpensive. And I don't think everyone necessarily needs, a panel for every child or adult that presents. But I think they're a really useful adjunct for diagnosis of suspected tick-borne illness. Again, in the acute infection, you get a rapid result that's very sensitive. And PCR can be recommended for Anaplasma, Ehrlichia, Babesia, and non-Burgdorferi Borrelia species. And again, you need a broad molecular panel approach. I don't think you can just pick out a few of these because, again, what I showed you, just the data from our broad testing, we found any number of pathogens, including those novel Borrelias. So how can we think about integrating molecular into our current diagnostic algorithm? If you've got someone presenting with illness during tick season, fever, chills, compatible symptoms, and a tick exposure, if they have that beautiful classic erythema migrans, then, you could look to see, are they immunocompromised? They have other risk factors for severe disease. If they don't, you still may be able to get away with just treating with doxy with the assumption that it's Borrelia burgdorferi. The PCR-based tests aren't that sensitive really anyway, and if you have just a classic case, you can do that. Now, after treating, you of course monitor, and if the symptoms don't resolve, if the patient gets worse symptoms, then certainly bring back and do that tick-borne panel. However, even if they have classic symptoms, if they're immunocompromised or acutely ill, then I think it's certainly worthwhile running a PCR-based panel, maybe even with a blood smear, because you're really interested in the co-infections. Babesia may self-resolve, and so if you miss it in a co-infection, maybe it doesn't matter for an immune-competent patient, but for a compromised patient, this could go very badly. So I think you need to look for those co-infections because, again, we found them in 6% of kids being evaluated for Lyme disease. If you don't have classic erythema migrans, then I think absolutely, go right for the tick-borne pathogen panel because it may not be Lyme, classic Lyme disease. So that's how I kind of think about fitting in the molecular tests with our existing testing modalities. So with that, I'll conclude, thank some of the collaborators from some of the studies that I presented, and I guess ask if there's any questions or comments. Dr. Chapin.
Thank you, Blake. That was awesome. So I had a couple of questions because I'm from New England, a lot of Lyme disease. And the problem we would always have diagnostically was people would order one test, then order a panel, and then order something else. Never got a good answer. So I love using the PCR panel. But one question, for immunocompromised patients, did you find Borrelia burgdorferi was positive more often in that patient group? That's one. And then I'm going to bring up the disastrous chronic Lyme. Like, what do you do when people continue to have symptoms, and then what do you do for diagnostics?
Yeah. As far as the immunocompromised, neither study had a huge population of immunocompromised. The adult study was just prospective adults coming in, presenting to the ambulatory environment. And the pediatric study was based on, again, children presenting to the ED. So not a huge compromised population. I think that's why in the pediatric study, we did see some admissions, but the impact of those missed co-infections maybe wasn't as large as you would have seen if you just restricted yourself to a compromised population. And which is why kind of my algorithm at the end, I say, if you're compromised, then go for this panel. You don't want to miss these. Your second question about chronic Lyme, yeah, is there really chronic Lyme or is it post-Lyme? Maybe that's nuanced. Either way, no, I don't think these PCR panels are going to help. Serologically, great, you're positive for Borrelia burgdorferi, and downstream of that, you never find evidence, joints aside, right? You never find evidence of the bug actually anywhere. So I don't know how this could be applied to those patients. I don't really see a role for it in those patients.
So, Kim, I'm going to respond to this. So, as you know, the AMA has staunchly come out against the diagnosis of chronic Lyme. It's actually the only set of practice guidelines that has been publicly sued. And when they sued, they kicked half of the advisors off of the panel, as you know, and they came up with the same recommendation. So for those patients that suffer from nonspecific symptoms as a sequelae of true Lyme infection, there is mounting evidence, as you know, better than anyone, that it really is the immune complex that provides those symptoms. In the context of a PCR approach, there is value to a patient to be able to clear them at low sensitivities that Blake suggested, 1-2 copies in the blood, to be able to provide that conversation piece between physician and patient that there's no evidence of Borrelia DNA in the blood. Now, that's a little bit of a touchy-feely response to you, but there is some suggestion that the ability of PCRs for Lyme does provide a little bit of a discussion point for those conversations to occur. So in that regard, there is some inherent value in having Lyme on a PCR panel for patients that represent with nonspecific symptoms.
Hi, Kathy Stelwick from Albany Medical Center. We're also in a heavy tick area. And did your studies look at whether a positive Babesia was due to a current infection versus past infections with the sequestered DNA from the liver? Our ID docs think that's a huge concern and they won't order a PCR for Babesia.
No, I mean, we did not drill down on that. I'm not quite sure how to approach that other than these patients were being evaluated for acute symptoms. I've never really thought of Babesia as a chronic persistent infection. You either convalesce and clear it or you get worse. As far as sequestering DNA in the liver, sure. I mean, there's, that's one of the, downsides of PCR is the exquisite sensitivity in absence of viable organism. It has to be a composite approach. Laboratory cannot solve everyone's problems, right? We're not Doc in a box. We're a piece of the puzzle that needs to be interpreted in the context. So I guess that's how I'd answer that question.
Hey, thank you for the presentation. So I wonder that you present that the PCR is definitely really good for have a very specific PCR or sensitivity from a certain like specific pathogen, right? I wonder that if that the lymph disease caused by different pathogens have different treatment for that. A second question is that follow with that, have you ever go down a little further that to instead of detect the PCR DNA, is that possible a way that to detect the response from the host response? So for example, like a certain very specific response from the host instead of one by one for the pathogen. Is that possible for that? Thank you.
Yeah, I mean, host response is an area that's getting a lot of excitement and research these days, largely differentiating bacterial, viral, but even down to some, different bacterial pathogens giving a different host response. I don't know that any of that's been looked at in the context of tick-borne illness. And your first question as far as, was it guiding therapy? Do they have different therapies? Yeah, I mean, many of the tick-borne pathogens fortunately respond to doxycycline. Babesia is one that doesn't. And so, yeah, I think it's important to call that out. So, yeah, one could conclude that, why do I care? I'll just treat with doxy. But, it's a pragmatic approach, but I think we miss out on a better understanding of the disease. And, maybe there's relapsed infections. I don't think with these new pathogens, until we actually get an appreciation and get a large N of diagnostics, what that clinical course looks like and what potential therapy failure rates look like. And so I think that's maybe yet to be fully elucidated.
Hey Blake, Kyle Rodino, University of Pennsylvania. I'm pretty much in agreement with your sort of targeted approach of the panel. And I can say that probably as like a large medical center place where we have people to read smears and do those things. But can I flip it for 1 second and ask your opinion on, as we become consolidated health systems and there's numbers of sites around, what is your opinion on the panel use at the satellite hospital for positive, negative, and then sending just the positives to the central lab for the smear, percent parasitemia? Do you think it's worth that role and that workflow or not?
I don't know of a lot of data around percent parasitemias. There's some for Babesia, right? And it certainly correlates with more severe disease, no doubt. So you could implement a workflow like that. It would probably depend a lot on the technology in your healthcare system. What types of platforms do you have available at the satellite labs? What are your turnaround time needs? That sort of thing. I know it's kind of a soft answer, but each system is going to be a little bit different. I would more use a reflexive approach from a negative smear because smears aren't awful for Babesia. They're fairly good and they're cheap and rapid. So you could integrate it that way. For anaplasma and Ehrlichia, I think it's no doubt PCR is better than smear. So maybe Babesia is a little bit of a, you may want to do a smear first. I don't know about, you certainly could reflex them for percent parasitemas. I mean, you'd have to if you wanted to count them. Could you grab the microphone there? Thank you.
So we are located in New York. We have a regulatory hurdles. We have to strike a 95% sensitivity. If the PCR is like a 40 or 50%, they're never going to approve. What is your recommendation on that?
So you're saying you have a high pretest probability and your sensitivity to smear is high.
Yes, the expectation is going to be high from the regulatory agency, right?
Yeah.
So if I am presenting like a 50 to 60%, it is not acceptable by regulatory agencies. So what is your recommendation to overcome these regulatory hurdles?
Well, the poor sensitivity is really related to Borrelia burgdorferi. And so,
that's my question is.
right, and so I'm not advocating for replacement for serologic tests or even clinical assessment and treatment in the classic cases. It would be up to the regulatory agencies to say, do we find value in this target even at only 50%, 60% for acute cases? I think the argument can be made that you do, and again, that was one of our findings. Our 9 positives were all serologically negative. not all cases present with a perfect erythema migrans. And so based on clinical grounds, those may not have been recognized. I don't know if that answers your question.
Yes, sir. And then we have another problem with getting the certified sample, especially for a DNA, to detect a DNA from the blood, because we are facing those problems. So how to address those problems?
So serum for serology, and you need whole blood for this. So
Yes,
you know,
for
collecting
the
like an
PCR.
EDTA tube and then a red top for your serology.
No, for the certified is a reference material.
Oh,
For
how to
the-
validate the test?
Yes.
Yeah, no, there's no doubt that that is problematic. And we had to phone a friend, so to speak, from Lyme endemic areas that had banked specimens that were tested either positive by a singleplex PCR. You know, who knows what the regulatory landscape's going to look like in the future as far as bars to validate. I can't predict the future, but you know, there's a general lack of reference material for a lot of these new tests, and that's something that hopefully industry partners could help with as far as coordination, connecting you with sites that have characterized specimens either serologically or by blood smear to help get those reference materials to help you validate a test like this.
Thank you.
So Blake, I'll ask one last question here. My question to you is about the lab director's voice for where the clinical microbiology community would feel comfortable advocating for molecular alongside a diagnosis of tick-borne disease. Turning away from Lyme for a minute, I live in a part of the country for which granulocytic disease is pretty common as opposed to monocytic. And it's not uncommon for us to see patients who present during the summer with fever of unknown origin, with a leukopenia, with or without a thrombocytopenia. And they'll send it for a morph, and the hematopathologist, if there's any hematopathologists in the crowd, will report it out as no morula seen, consistent with tick disease. Please consult with microbiology studies and or the use of molecular studies. And this is a pretty common report now from HemePath. And unlike Lyme, which was the question asked earlier, there seems to be emerging data for molecular as a semi-gold standard for ehrlichiosis, for anaplasmosis. But that diagnostic window is early. And certainly to the question that was asked earlier, we have tests on the market that are not 100% sensitive. TB PCR is one of them. And I can see the analogies with tick. There's great data on smear positivity, as there is in TB, but we're dealing with 75, maybe 85% sensitivity of TB PCRs in practical reality in the field. So where do you see, if you're looking into your crystal ball, where do you see tick-borne PCR tests incorporated, supplemented, used as two-tiered approaches in tick disease going forward?
Yeah, I mean, I think that's kind of what I kind of showed on the last slide, and I'm not saying this is something that has to be followed or will bear out to be perfect, but because I think there's no doubt that Borrelia burgdorferi still causes the burden of tick-borne illness, and many of those do have a fairly characteristic rash, and we don't have anything for the good acute cases, and so I'm not throwing away serology for those, but like I said, for the high-risk patients, I think what we're finding through these epidemiologic studies and casting a wide net is that co-infections are out there, and those lead to potentially higher risk disease, worse outcomes. So that's where I think you pair it with a serologic approach, or even, maybe even as an upfront, depending on if you send your serologies out or not. I think the ability to bring this in-house changes the algorithm a little. If I have to send this out, but I do serologies in-house, I might do the serology first. Whereas if I can bring this in-house, maybe this is a test that I order. And I can tell you from ID, for immune-compromised patients, they are always asking for the tick-borne pathogen panel. It's hitting their radar, and right now you're stuck between sending it to a couple of different reference labs, which if you've looked at them, have different organisms on their panels, and so you get stuck again kind of predicting that epidemiology, which again is where a really comprehensive panel that you can do on site and actually turn it around same day can be quite impactful for these and even help reduce your cost by bringing that testing in-house if you do a significant number of these.
Wonderful. Well, if there's no more questions, please thank me and join me in thanking Dr. Buchan for the wonderful talk and oversight on tick disease. Please continue to feel free to talk about tick and diagnostics over your lunch and dinner, and if they enter your dreams, that's fine too. Thank you, Blake, for a wonderful overview of tick-borne disease and tick-borne testing. Thank you.
Thanks.